Yeah.
There you go. I was like, yeah. So the whole room is mic'd. So. Did you already start? Oh, okay. All right, today's presentation is being recorded and will be offered on demand for those unable to attend in person. This activity is being accredited through a joint providership with CME Consultants. If you are attending in person, please sign in on the sign-in sheet, and the sign-in sheet will be sent to CME Consultants to verify in-person attendance. A CME evaluation form and post-test are included in the email for the documentation. Everyone who would like to receive a CME certificate must complete the evaluation form and submit it to CME Consultants to receive CME credit. If you're watching the recorded presentation, you must also submit and pass the post-test. The planners and faculty for this presentation have nothing to disclose, and there is no commercial support for this activity. Please also note that we are recording and there are microphones throughout the room, and they do pick up side conversations. Thank you, and now I'd like to introduce Dr. Poliakin.
Thank you. I guess this is for COVID, right?
No, you don't have to go back.
Oh, okay.
Yeah.
Hi, I'm Dr. Laura Poliakin. I'm a general surgeon, bariatric surgeon, and obesity medicine physician. And I'll be presenting today metabolic and bariatric surgery, current trends and new directions. I have no disclosures. So as we all know, obesity is a chronic lifelong disease. The U.S. obesity prevalence is up to 41.9%, and this is since 2017 to March of 2020. Probably the next set of data will show that there's a rising prevalence. As we could see from the previous data, it went from 30.5% to 41.9%. Might be a little small. So just some of the potential causes of obesity. So 70% of the time, it's really hereditary and genetic. It's just how does that patient act on the genetics and hereditary cause of obesity. So usually has to do with behaviors or the environment. So some iatrogenic causes are drugs that can cause weight gain. Then some dietary reasons, so like high-fat diets, keto diets, overeating, frequency of eating, and then there are some like endocrine causes, so hypothalamic obesity, hypothyroidism, Cushing's disease, PCOS, and then there's some behavioral factors, so this is like binge eating, psychological factors, night eating syndrome, sedentary lifestyle, and then just on the right-hand side, there's obesity effects, so like what does obesity cause in these patients. So some patients will have higher risk of stroke, heart disease, high cholesterol, hypertension, sleep apnea, diabetes, gallbladder issues, kidney disease, infertility, joint pain, and then cancer. Cancer is sometimes something that's not thought of as a risk factor with obesity. So there are some patients that have no other risk factors, and obesity may be the only one, like in breast cancer or endometrial cancer, pancreatic cancer, and I'll go over that again in a little. So some weight loss options for patients. So what we use is BMI, and this is something that is usually done in most like primary care offices, some specialty offices, but it's standardized. So not the most accurate way of predicting like fat percentage in a patient, but at least it's something that most offices are able to obtain. So with patients that have a BMI of 27 or higher with a comorbidity related to obesity, so like high blood pressure, high cholesterol, diabetes, these patients can be offered anti-obesity medications. Patients that have a BMI of 30 and higher are also in that category. And then patients that have a BMI of 35 or higher with comorbidities or BMI of 40 and higher, they can be offered bariatric surgery, which we'll be talking about more today. So as of the end of 2022, we now have new guidelines and indications for metabolic and bariatric surgery according to ASMBS, which is the American Society of Metabolic and Bariatric Surgery. So now what's being proposed to insurance companies, and hopefully insurance companies will start making these changes, is that patients can be bariatric surgery candidates with a BMI of 35 and higher. With or without any obesity-related comorbidities. So like I was saying before, high blood pressure, diabetes, sleep apnea, hyperlipidemia. And then the other category of patients would be a BMI of 30 to 34.9. and the patients also have history of type 2 diabetes. Another category, patients with a BMI of 30 to 34.9 who cannot achieve any type of weight loss, or they cannot sustain the weight loss, or there's no comorbidity improvement with non-surgical weight loss options. These patients would also fit the category. So this is different than the indications that have been around since the 1990s. And then there's also a consideration for race. So the patients that are in the Asian population, they're at higher risk of diabetes and cardiovascular disease, and this is related to higher prevalence of truncal obesity, so this is like visceral fat. So with these patients in the Asian population, they should be considered for bariatric surgery with a BMI of 27.5 or higher. Like I said, insurance hasn't changed criteria yet, so this is since 1991. Maybe they will change it this year, I don't know, but that's what the ASMBS was proposing. So as of right now, insurance will cover candidates for bariatric surgery when their BMI is 40 or higher, or if their BMI is 35 to 39.9 with at least one serious comorbidity related to obesity. So again, like high blood pressure, sleep apnea, diabetes, high cholesterol, fatty liver, things like that. Contraindications to metabolic and bariatric surgery include untreated major depression or psychosis, uncontrolled, untreated eating disorders like bulimia, current alcohol and drug abuse, severe cardiac disease where a patient cannot undergo general anesthesia, severe coagulopathy, and then the inability to comply with nutritional requirements. So these patients after bariatric surgery need to take vitamins lifelong. So if that's a patient that cannot, then that would be a contraindication. For sleeve gastrectomy specifically, an absolute contraindication is long segment Barrett's esophagus, which I'll go over. And then relative contraindications, history of cancer within the last 5 years, liver cirrhosis, inflammatory bowel disease, Down syndrome, and intellectual disability. If anyone has questions, you can also just interrupt me, by the way. So I'll go over the different procedures for bariatric surgery. Sleeve gastrectomy, this is now the most common weight loss surgery performed in the United States. The first one was performed in the 1990s, and a laparoscopic sleeve gastrectomy, first one was in 1999, so it's relatively new-ish. What happens during this procedure is 80 to 85% of the stomach is removed. So this is most of the greater curvature, so it's this light pink portion here, which contains the greater curvature, and then the fundus of the stomach. The fundus, the most important part that needs to be removed is the fundus of the stomach. So this is the part of the stomach that can expand and store all of our food and liquid. It can expand up to like 7 liters. So when we remove this portion